Good evening. At the onset, I would very much like to thank the organizing committee of the BGNI International Cancer Conference for inviting me to be with you this evening. In particular, I want to thank Russia and Merit, and my only regret is that I cannot be in Cairo to personally interact with all of you. The first topic of discussion that I will have with you this evening is on parenchymal asymmetries, their definition, evaluation, and management. And I think to put this in context, we need to go back a little bit in history and describe the starting point for the BI-RADS lexicon and our current status on parenchymal asymmetries. The first ACR BI-RADS lexicon book, the first edition, was published in 1993. It was a thin pamphlet, basically, dealing with descriptors and things like that. This has rapidly evolved over the last several decades to the most recent publication being in 2013. It was the 5th edition. This edition includes 763 clinical images. Not only does it have a section on mammography, it has a section on breast ultrasound, breast magnetic resonance imaging, a data follow-up and outcome monitoring, and a data dictionary. And it is this atlas that forms the basis for my presentation this evening. With respect to parenchymal asymmetries, we're going to talk about asymmetry or tissue superimposition. We're going to talk about focal parenchymal asymmetry. We're going to talk about global parenchymal asymmetry, and we're going to talk about developing parenchymal asymmetry. Although it is self-evident, I think it is important to emphasize that when you talk about asymmetry, you need to have both breast. Otherwise, the term asymmetry doesn't apply. Likewise, for developing asymmetry, you need to have both breasts, but you also need to have prior studies to establish that, in fact, the asymmetry has been changing or evolving over time. Distinguish this from asymmetric breast size and accessory glandular tissue. Asymmetric breast size may be associated with parenchymal asymmetry, but this is a situation where the key thing actually is to discuss with the patient, verify that she has always had one breast that is smaller than the other breast. With respect to accessory glandular tissue in the axilla, it is usually unilateral. You will see no correlate in the cranial caudal views. In some women, you may image it in the XCCL projection if you do that, but patients may describe cyclical symptoms of pain, fullness, particularly with their cycles associated with the glandular tissue, because like the breast parenchyma, this is breast tissue and it will cycle with the patient. So she may be intermittently symptomatic from this. With respect to the detection of parenchymal asymmetries, as I'm going to emphasize throughout this entire half hour, a critical review of images. You have to send your brain out actively and aggressively looking for it. You have to prepare your brain to see it. Ask the question, is there focal parenchymal asymmetry? Is there a developing parenchymal asymmetry? When you ask those questions, it forces you to consider it and look at the image critically and specifically looking for this. As I said, you want a bilateral study, and in the case of developing parenchymal asymmetry, you want the prior studies. Make no assumptions about any finding. Let the images, let your evaluation, let your physical examination take you where it's going to take you. It's probably going to direct you in the right direction, and it's going to direct you to the right recommendation and appropriate management for the patient. In terms of a differential, parenchymal asymmetries are often normal variation. You can have accessory glandular tissue, as I just showed you. Keep in mind that if a patient has had surgery to one breast with removal of tissue on subsequent mammograms, the contralateral side may now appear to be asymmetric because there's tissue there that's been removed from the other breast. If the patient is on estrogens, you may see a change. If the patient has stopped taking tamoxifen, you may see glandular tissue or islands of glandular tissue blossom after the tamoxifen has been stopped. And in terms of pathologies, focal fibrosis, pseudoangiomatous stromal hyperplasia or PASH, trauma, Fat necrosis, again, history is very important. And mastitis, what are the physical findings? Is the patient tender? Is there erythema associated with the area of parenchymal asymmetry? With respect to the malignancies, invasive lobular carcinoma, invasive ductal carcinoma, carcinoma in situ, and lymphoma very rarely can present as a parenchymal asymmetry. So let's first talk about asymmetry or superimposition or summation, if you will, of tissue. This is tissue that you see in one of two standard views. You don't see it on any additional views. It is not breast cancer. It requires no biopsy. And frankly, it usually doesn't require any additional evaluation. It's something that you should be able to manage on the standard views. You need to make sure, however, that the tissue that you're looking at hasn't been excluded from the field of view on the orthogonal view, or that the tissue you're focused your attention on isn't being obscured by surrounded glandular tissue. So for example, in this patient baseline screening mammogram, you can identify an island of asymmetry laterally in the right breast, but when you look at the medial lateral oblique view, you've got lots of pectoral muscle, so it's unlikely that this tissue has been excluded. And when you look at the expected location of this tissue in the MLO view, there is no correlate for it. This is basically superimposition of glandular tissue, and you don't need to do anything additional. In this second patient, you can again see an area of asymmetric tissue with respect to the right breast, but when you look at the medial lateral oblique view, there is no correlate. If you measure back from the nipple on the CC view, you measure back from the nipple on the MLO, there's absolutely no correlate in the expected location of the approximate size on the MLO view. This is basically asymmetric superimposed glandular tissue, and it requires no additional intervention. This is something you can resolve on the screening images. In terms of evaluation, prior films may help you, getting a history from the patient. Rarely indicated, however, if for some reason you remain concerned about an area in one projection, then I would suggest that you spot it in the projection in which you see it, or if you haven't done tomosynthesis, do tomosynthesis in that projection. And if it resolves on the spot on the additional view, stop. If you're only seeing it in the CC view, and with your additional evaluation, your spots, your tomosynthesis, you cannot identify a finding there, don't start looking for something on the MLO view, because obviously it's normal glandular tissue. Very rarely would I do correlative physical examination, ultrasound in these patients. These are issues that I can usually resolve on the screening images and with prior films. Now, what about focal parenchymal asymmetry? This is something that you see in at least two different projections. It occupies less than one quadrant of the breast. And very importantly, there is no associated mass, no calcifications, and no distortion associated with this. It is not palpable. And if you do an ultrasound, it's either normal or you have a benign finding on ultrasound. You're going to find this in approximately 1% of all screening mammograms. So in this patient, for example, if I do this, you can see that there is an island of tissue that you see in both the CC and the left MLO. It is posterior in the upper outer aspect of the left breast posteriorly. This is what we're going to call focal parenchymal asymmetry. And depending on whether you have prior views or not, you're going to evaluate it further. Here's another example of focal parenchymal asymmetry. It's the same approximate size. It's the same location. It correlates on the two projections. It occupies less than one quadrant to the left breast. This is what's defined as focal parenchymal asymmetry. With focal parenchymal asymmetry in terms of the evaluation, you want to prior films, you want to have history, make sure that this isn't related to surgery, for example, make sure that this isn't a function of a mastitis or an inflammatory process. If you can't clear it on the standard views or with the history, and you haven't done tomosynthesis, you might start by doing tomosynthesis or not. You can do spot compression views in both projections. You can do correlative physical examination, and you can do ultrasound to fully evaluate that area. Very rarely with a focal parenchymal asymmetry would I do MRI, and very rarely would I do a biopsy. And it would, if I only see it on the mammographic images, it would have to be done stereotactically. Keep in mind again that with tomosynthesis, a lot of callbacks for focal parenchymal asymmetry are being eliminated at the screening stage, because when you do the tomo, you can actually, as you scroll back and forth here on the CC view, you can see that this is normal glandular tissue. There's no underlying mass. And here on the MLO, again, if you focus your attention superiorly, as I scroll back and forth into and out of that tissue, it is basically glandular tissue with no associated distortion, no associated underlying mass with this. If there are no prior studies and you have called back the patient and you have done additional views, you've done an ultrasound and a physical exam, what you can do is put this into the BI-RADS category 3. It has less than 1% likelihood of malignancy, so it is something that you can safely put into the BI-RADS 3 category. The likelihood of malignancy, as I will share with you in my second lecture, is very low. After 2 to 3 years, once you've established stability of this area, you can return the patient to screening, because it is virtually 0% likelihood of malignancy. And depending if on that screening mammogram you describe the focal parenchymal asymmetry, I would give it a BI-RADS 2. If you do not describe it, I would give the mammogram a BI-RADS 1. Again, this is after you've established stability for the finding. So let's go through one more example where you have focal parenchymal asymmetry. On the routine views, you could actually wonder if there is an underlying mass in this area. So this is a patient who has no history of breast surgery, but we have no prior studies. So she becomes a BI-RADS 0. We need additional imaging evaluation. On the spots, we see that this is starting to look very much like glandular tissue. There's no associated distortion. There's no underlying mass. You can do an ultrasound, and on ultrasound, you find a few scattered cystic and ductal structures that are minimally distended, but normal tissue interfaces, normal echogenicity to the tissue. So at this point, I would make this a BI-RADS 3, probably benign finding, and I would recommend a 6-month follow-up. And as I said, we'll come back to this topic of the BI-RADS 3 during my second lecture. On the other hand, once you get a finding that is palpable and there's associated distortion, this is not a probably benign finding. This actually requires additional evaluation and likely requires a biopsy be done, unless you can correlate it to an area of mastitis, prior surgery, or trauma. But most of these are going to, in fact, require biopsy. Likewise, in this patient, you have focal parenchymal asymmetry in the upper outer aspect of the right breast. When you do spot compression views, you can see that there are associated calcifications. This is actually a BI-RADS 4B lesion, and a biopsy is indicated. Here's the patient's MRI showing non-mass-like enhancement that is segmentally distributed, and this is, in fact, a patient with ductal carcinoma in situ. Now, what about global parenchymal asymmetry? This is a greater volume of tissue in one breast compared with the corresponding area in the contralateral breast. It occupies at least one quadrant of the breast. There is no associated mass calcifications or distortion. You're going to see this approximately 3% of your screening mammograms. It's almost always a normal variant, but not always. So again, evaluate the tissue carefully for any associated calcifications, distortions, or masses. And this may be seen in conjunction with asymmetric breast size. So here's an example of global parenchymal asymmetry where you have a greater volume of tissue in the right breast compared with that area in the left breast. It occupies one quadrant of the breast, but there's no associated mass, calcifications, or distortion. This is the definition of global parenchymal asymmetry. Likewise, in this patient, you have a greater volume of tissue in one breast compared with the corresponding area in the contralateral breast. There's no associated mass calcifications or distortion. This is global parenchymal asymmetry. Again, beware, however, that once you start getting associated masses or you see associated calcifications and distortion, this requires additional evaluation. And in this patient, this happens to be invasive ductal carcinoma presenting with global parenchymal asymmetry. So again, as long as there is no associated calcification, distortion, or underlying mass, you're okay to follow these, especially if you have prior studies. Otherwise, evaluate the area, do a physical exam, do an ultrasound, and make sure that there's nothing underlying what appears to be global parenchymal asymmetry. Here's that patient's MIP image on the MRI, and you can see here the pre-contrast images and the post-contrast images. She has some dilated ductal structures and a significant area of enhancement associated with the asymmetry identified mammographically. She also had intramammary and supraclavicular lymph nodes at the time of diagnosis. Global parenchymal asymmetry in this patient associated with many calcifications. The breast is smaller, and this is the MIP image on this patient. Here's the pathology from this patient. This is actually a patient with extensive intraductal carcinoma in situ, and you see these comedos, you see these dilated ducts associated with comedos within it. So beware of global parenchymal asymmetry with associated calcifications. Now, it is developing parenchymal asymmetry that you need to be on the lookout for. You need to be very careful. You need to evaluate these patients carefully. You need to have both breasts to determine asymmetry. You need to have prior studies to describe it as developing. It's usually focal, though if it's hormone related, such as being started on estrogen, or as I mentioned before, if you were on tamoxifen and the tamoxifan's been stopped, you may see a rebound. It may be more diffuse and bilateral. You are looking for a new, larger, or more conspicuous. It's an infrequent finding in about 0.2% of screening mammograms, 0.1% of diagnostic mammograms, but it does have a higher likelihood of malignancy than the other two types of asymmetries we discussed. It is 13% when identified at screening, and over a quarter of the patients will have an underlying malignancy when it is identified in the diagnostic setting. So here's a patient with a screening mammogram, and on a subsequent mammogram, you see that there is an island, a focal parenchymal asymmetry developing in the upper outer aspect of the right breast posteriorly. On the spot compression views, you identify this as normal glandular tissue. Notice how much it changes between the two projections. There's no underlying mass. There's no distortion. Her ultrasound was normal. In discussion with the patient, she elected to have stereotactic biopsy. We sampled this area extensively, and it is in fact an example of pseudoangiomatous stromal hyperplasia presenting as developing parenchymal asymmetry. In this patient, again, I'm showing you the current study where you see asymmetry in the distribution of the breast parenchyma, but it's only when I show you her prior studies that you can describe this as developing asymmetry. It actually involves both breasts. It's fairly diffuse. And this is a patient that has been started on estrogen, and that is the reason for the developing parenchymal asymmetry. Here's another patient where, again, we have a screening mammogram that I'm showing you here. You can describe asymmetry, but it's only when I show you the prior studies that you can talk about developing parenchymal asymmetry in the lower central portion of the left breast. Posteriorly, here are the spot compression views. This underwent stereotactic guided biopsy, and it was a 3.5 centimeter area of invasive lobular carcinoma associated with lobular carcinoma in situ, as well as ductal carcinoma in situ. She had sentinel lymph node was negative. This was ER positively positive, PR weakly positive, HER2 neu by FISH positive. Now, with developing parenchymal asymmetry, this can be quite subtle. How do you increase your perception? What sorts of things can you do so that you can perceive it? Again, both breast and prior studies, actively look for it. Prime your brain to see it. Is there developing asymmetry? Use studies from multiple years for comparison. compared to the earliest study of comparable quality. Line up the MLOs and line up the CCs from consecutive studies. Or one of my favorite tricks is to take the current MLO and the earliest MLO I have for comparison, flip it so that I can compare one-to-one that breast from one year to the next. So for example, in this patient, you have an area of asymmetry in the left breast upper central part. It seems rather elongated in the CC projection. That's in 2014. This is what she looks like in 2012. How can we increase our perception? Again, if you put the 2012 back to back with the 2014, you can appreciate the changes on both the CC and the MLO views. Or if you line up the MLO views, you line up the CC projections, you can appreciate the change that has occurred over time in terms of the developing asymmetry. Here it is on the spot compression views. Here it is on ultrasound. You can see that this is actually palpable. You can see the irregular area of hypoechogenicity, and the diagnosis in this patient was established using ultrasound-guided biopsy of this area. Here's her pre-contrast and post-contrast MRI showing very nice correlate with the oblique view here, this coat of tissue. And in the CC view, you notice that it's more planar, if you will. This is actually extensive ductal carcinoma in situ with multiple foci of invasive ductal cancer. The largest focus measured 0.7 centimeters. Let me show you one more example. And here again, if you're doing 100 screening mammograms in a day, or even 50, if you're not specifically asking yourself, is there parenchymal asymmetry? This is quite subtle. You might in fact miss it. I take the earliest study for comparison, and now I have developing parenchymal asymmetry in the right breast. And if I do this trick of comparing the right CC in 2015 with the right CC in 2013, you can appreciate that this is indeed developing parenchymal asymmetry. It's a bit on the diffuse side, but there it is. And similarly on the MLO views, it becomes a lot easier to establish that this in fact is developing parenchymal asymmetry. You again want to make sure that there's no history of estrogen use, no history of tamoxifen, no clinical symptoms to suggest a mastitis, etc. But if you're left with nothing else, this needs to be further evaluated. As I said before, the other very nice way is to line up the CC views, line up your MLO views, and you can again see how slowly this has evolving. So if you just compare 2015 with 2014, you may not perceive it. However, when you compare 2015 to 2013, it is relatively easy to appreciate that the patient has developed parenchymal asymmetry. And here are her pre-contrast and post-contrast sagittal reconstructed from the MR. You can see that she has some cystic area, some ductal structures and cysts that are dilated on the pre-contrast images, but the tissue surrounding those fluid-filled areas in the breast enhances. This again is an extensive ductal carcinoma in situ with areas of high nuclear grade DCIS. So in conclusion, what we have discussed are asymmetries, superimpositions that really you can establish on your standard views by comparing one breast with the other, by looking for location, looking for size, the focal and global parenchymal asymmetries, and most importantly, the developing asymmetry having prior studies. I have given you concepts for evaluating these, for how these are defined, and what's an appropriate management. And please keep in mind, you have to have critical image review, prior films, history, and complete evaluations. Thank you very, very much.